So this presentation is just a summary of a project to model the changing demand for mental health care to help a National Health Service trust in the UK plan for its future delivery of capacity to help tackle the mental illness crisis. Expressed demand for mental health care, which is way higher than the capacity of the system to serve that demand. And that results in too slow reduction in cases. People move through the levels of mental illness more quickly. And we end up with lots of people not presenting for treatment. There's lots of mental illness out there that we just don't know about. And we also know that expressed and unexpressed demand will continue to grow, accelerated by the community stresses caused by coronavirus. And we further know that staff capacity was already inadequate for the levels of mental illness that required help before coronavirus, and it's just going to be even more inadequate with the additional cases coming through due to coronavirus, and none of it can be fixed quickly. We can't train therapists quickly, we can't train nurses quickly, we can't train doctors quickly. The requirements here, well, first of all, we've got to encompass the whole system, because issues in any part of the system unavoidably affect other parts. The model's got to be simple enough to understand and use, and show implications for staffing requirements, costs, of course. It's got to be long enough in its timescale for planning goals. This is a very long timescale issue, but it's got to be short enough time units to capture what's happening in shorter periods. We'll split out significant details later. We'll split out the different types of mental illness and different groups on the supply side. And it's got to be capable of calibration and use at different geographic levels, right from GP practice right up to the whole of the country. So we did a proof of concept model first, just to show that a model is practically possible and to seek funding. So first of all, who does what along the pipeline? Well, here's the people getting mild symptoms, moderate symptoms, severe symptoms across the top. And there is a lot of self-management and community management and support group management in the green block there for people with mild to moderate cases and to prevent mental illness in the first place. Then there's primary care, looking after people with mild and moderate symptoms. Somewhere along the mild to moderate spectrum, then secondary care capacity comes in. So this is psychiatric nurses and community mental health teams attached to psychiatric mental hospitals. And then you've got the support from the voluntary sector going along the bottom as well. So here's the essence of the mental health challenge. Getting stress makes you more likely to become ill per month. So the number of mentally ill people increases, and with coronavirus adding to people's stress, that increases the rate at which people become mentally ill. And then you have mental health professionals providing the capacity to help people recover from that. This is the working model that captures what I just showed you. We've got people with no excess stress becoming stressed, and that's causing them to move from no mental illness to becoming mentally ill. And the capacity of the mental health professionals limits their ability for those people to be helped to recover. So in the blue scenario here, we're assuming that overload does not affect mental health staff's ability to help people recover. In the purple case, we're assuming that it does. So with overload slowing the rate people recover, you end up with more people remaining mentally ill. And we go through this process of explaining to our audience exactly how these models work. So here's what we do to expand that simple model. We add these additional features. In particular, we're splitting out primary and secondary care and the inpatient cases for people with the most severe illness. So here's an overview of that whole model. There's the number of stressed people pushing cases to become mentally ill in the first place, and then to become moderately or severely ill. There is the parallel stock of hidden cases that we just don't know anything about because they don't show up and ask for help. There's the recovery rate, which is enabled by GP capacity, therapists, primary care, nursing, and the voluntary sector. And if there isn't enough of that capacity, then GPs have got no choice really but to put people on drug therapy. There isn't enough therapy capacity, so new cases get put on waiting lists, and how many people do get therapy depends on how many therapists are available, and there's a training lead time there. There's a very similar training pipeline for nurses. Qualified mental health nurses may work in primary care, but some of them work in secondary care as well. And moderate and severe cases get referred to secondary care support, which may involve help from specialist consultants. We have a training pipeline for doctors, and then there is that workload on the doctors and on the nurses that comes from the balance between their caseload and their capacity to help those cases. And any overload there slows the rate at which people recover, and any overload also leads to an excess rate of nurses and doctors retiring early or leaving the profession. Some doctors become consultants, and they provide more specialist support, and some of those severe cases need inpatient care, and whether they get that care depends on the number of places available. If that number of places is not available, then those cases end up being outplaced with third-party providers at considerable extra cost. And here's just one section of the model playing out the pipeline of doctor training. You've got doctors coming in at the lower left there. They are in their core psychiatric training in the middle. They become qualified psychiatric doctors, and over on the right they may choose to become consultants. And the section in the middle is showing the capacity of those doctors to help moderate and severe cases. Some doctors don't complete training. Some of doctors during their training actually do provide some capacity, not the capacity of fully qualified doctors. A fraction of qualified doctors seek consultant promotion, and consultant numbers limit the moderate cases that they can see. And then the total secondary care cases drives the workload on both doctors and nurses, and that slows the rate at which patients recover. The model's been endorsed by mental health professionals, but there's much more to do yet. We will calibrate it for contrasting regions, and that will lead to disaggregation of some of the elements I've just shown you. The model will then be made available to professionals and in particular to those responsible for planning the mental health system in mental health trusts.